Welcome to our webinar today. It is part two of our three-part series on improving cancer care for rural communities. My name is Nora Barnett, and I'll be the host today. My colleague Miles is also here, and he'll be providing technical assistance and monitoring the chat box with me. Uh, the title of today's session is Implementing Scalable Exercise Interventions to Address Supportive Care for Disparities in Rural Cancer Survivors. And we are so pleased to have Jessica Susan Gorslit as our guest speaker today from the University of Iowa. Before we begin, a few logistical things. Please use the Q&A box for any questions for our guest speaker and the chat box to share your comments. We'll queue up your questions and we'll have time for questions at the end. Closed caption is available by clicking on the icon that says CC at the bottom of your screen and then selecting captions. The session is being recorded and a recording will be sent out to participants within 2 weeks. For those of you looking for continuing education, this webinar offers CHES credit or Certified Health Education Specialist credit, Certified Nursing Education credit, and Medical Library Association credit. At the end of the webinar, there'll be a link to an evaluation. And when you fill out that evaluation, you'll then be able to claim your CE credit. And even if you're not claiming CE credit, we'd love it if you would fill out that evaluation, because it helps us improve our programming. This webinar is brought to you by the Network of the National Library of Medicine. For those of you who are not familiar with the Network of the National Library of Medicine, also known as NNLM, we are a program of the National Library of Medicine, which is one of the 27 institutes and offices that make up the National Institute of Health. We are based at offices and centers around the country that represent different regions, but we also work across the country to provide education and funding opportunities. I encourage you all to visit nnlm.gov to learn more. So I'm delighted to introduce our speaker today, Dr. Jess Susan Gorslitz. She is an assistant professor of health promotion at the University of Iowa, with joint appointments in health and human physiology and obstetrics and gynecology. Her research centers on exercise oncology and cancer survivorship, with a strong focus on addressing rural health disparities. She develops and evaluates scalable, remotely delivered exercise intervention to expand access to supportive care for cancer survivors in underserved communities. Dr. Gorslitz also serves as an assistant program leader for cancer epidemiology and population sciences at the Holden Comprehensive Cancer Center and has authored more than 45 peer-reviewed publications advancing the field of rural cancer survivorship and remote exercise oncology. Thank you for being with us today. And now I'm going to hand the mic over.
Great. I am going to share my screen. Okay. Thank you for the opportunity to be here today. It's a great privilege to talk about our work, and not just my work, the group I work with in Iowa from all across the state. And in particular, Nora, thank you for the setup and this opportunity. Today, there are 4 main objectives I'd like to cover. We are going to talk about this throughout the presentation, but in order to talk about implementation of exercise oncology programming, it's really important to understand why exercise is so important and therefore the associated health outcomes for older adults. Basically, why is exercise good? Then we're going to talk about rural communities in particular, identify some of the disparities, some of the gaps in rural places, and why some of the current interventions and things that are happening nationwide may not be the best fit for rural areas. And finally, I'm going to talk a bit about the Iowa Cancer Affiliate Network, which is where we've done some formative work to look at implementation within one specific statewide context for future areas of implementation. And we've got this split out into three parts. We'll take little breaks in between these sections. We'll start off by talking about that evidence base. And if you're watching online, feel free to stand up, move your legs, walk away from the screen. Every time I talk about exercise, I feel like I need to be on a bike as I'm standing here talking. Then again, we're going to talk about rural areas in particular, and finally with ICANN. And like Nora said, I encourage all questions, comments, feel free to put them in the chat. I look forward to a hearty discussion at the end of the presentation today. So exercise is really important for both cancer patients and for survivors as well. When we're thinking about cancer survivors or talking about cancer survivorship, I use the definition from the National Cancer Institute. So a cancer survivor is a person from the moment they are diagnosed throughout the balance of their life. And survivorship isn't just worrying about their disease coming back. There are multifactorial concerns that include physical, mental, psychosocial, interpersonal, sexual, or maybe even financial concerns related to a cancer diagnosis and then going forward throughout the balance of their life. So survivorship care isn't just getting through that primary treatment. There are concerns that can include late effects of treatment, such as cardiotoxicities or neuropathies that show up years after the disease, cancer coming back, new cancers, and general quality of life. The cancer survivorship space is pretty robust. The National Cancer Institute, for their 25th anniversary of the Office of Cancer Survivorship, published this comparison of their portfolio, showing on the left where the survivorship literature, where their funding was in 1998 compared to 2020. Okay, so now on the slide, you can see the difference in the Office of Cancer Survivorship's funding portfolio from 1998 until 2020. So again, on the left side here, you'll see that there was a robust funding area primarily focused on breast cancer and childhood cancer. Comparing that to 2020, there are far more topics showing the complexity and the changing field of survivorship that although breast cancer survivorship is quite prevalent and well represented, there are way more dimensions that are the Office of Cancer Survivorship's funding, such as palliative care, Medicare research, and long-term concerns of cancer survivors. They also put out a call for the future. Some of the areas on the bottom of the slide identify where they recommend future research. And I'd like to point out on the left the importance of understanding disparities among cancer survivors, which is where rural cancer comes in. And on the far right side, incorporating implementation strategies to take our evidence-based practices and put them into practice. Unfortunately, cancer survivorship is a good job security. This is from a publication called Anticipating the Silver Tsunami, which showed the anticipated growth in cancer survivors over the next 20 years at the time. And this figure shows that not only will we have more cancer survivors than ever before by 2040, but these folks are going to be living longer with complications associated with their cancer treatment, coupled with aging-related concerns. And the hypothesis is that those two interact, that it's not just aging comorbidities or cancer-related comorbidities, but that the healthcare needs and the complexities of survivorship care will be far more robust than they are currently. When thinking about what survivors need in terms of healthcare, I really like this framework from Larissa Nekledoff that shows the multiple layers of care necessary for survivors. These include concerns about management of physical effects, psychosocial concerns, chronic conditions, etc. Where I fit in is really that health promotion and disease prevention on the bottom left-hand side of the screen. Exercise is associated with improvements in a lot of these physical related effects, as well as the mental health effects as well. In 2019, our field had two seminal articles published, position statements, and international expert roundtable from the American College of Sports Medicine. The first one, led by Dr. Patel, showed that exercise and physical activity were associated with prevention of 8 different cancer types. But in the bottom part, led by Dr. Kristen Campbell, they published the exercise guidelines for cancer survivors. So these two publications coming out at the same time were really transformative for our field, showing with good evidence that exercise prevents cancer, but then also for folks after they have been diagnosed, what should they be doing for maximizing their health outcomes? And this graphic shows at the time of the publication, so in 2019, where the evidence was for specific outcomes. So for example, for cancer-related fatigue, which is a very common reported symptoms for cancer survivors of all types, that the dose of aerobic exercise, which in the literature was 3 times a week of 30 minutes and 30 minutes duration, was associated with clinically significant improvements in fatigue. Now, this position statement looked at the body of evidence. So these are some observational trials, these are some experimental trials, and each of the trials will test their own dose of exercise. So in the columns here, that's why you can see for some outcomes, there is a very specific dose of aerobic exercise, but insufficient for resistance exercise, for example. It's not that resistance exercise isn't helpful. It's just at the time, there was insufficient evidence to make a recommendation there. At the time of publication, there was also moderate evidence for exercise improving bone health and sleep. So these guidelines helped inform the American Society for Clinical Oncology, publishing their recommendations in 2022, which was really, again, transformative for our field, saying that oncology providers should be referring patients who are on curative intent therapy to exercise programs. Oncology providers should be telling their patients do aerobic exercise and do resistance exercise, which is fantastic. We love to have the providers recommend that. There are barriers to implementation of that, which we'll talk about. Not only does the American Society of Clinical Oncology recommend exercise for cancer survivors, the American Cancer Society as well recommends physical activity for individuals during treatment and into survivorship. In particular, they recommend physical activity assessment and counseling begin as soon as possible during diagnosis. So for folks who are undergoing treatment, that can include that physical activity counseling recommendation and connection with exercise resources. On the right-hand side of the screen here, in particular, the American Cancer Society endorses a volume of aerobic exercise. Now, that aerobic exercise is that gets your heart rate up, breathing heavy, and sweating. So for some people, this is power walking, maybe running or going for a bike ride. The dose for health benefits is 150 to 300 minutes per week. So that's about 2.5 hours to 5 hours a week of at least moderate intensity. And generally to move more and sit less. They also have recommendations for children as well. The American College of Sports Medicine will provide more specificity here, given that it's also an exercise-based organization, that they similarly endorse avoiding inactivity wherever possible. And they too endorse the minimum threshold of aerobic exercise of 150 minutes per week. And with these types of exercise levels, they can be accumulated in bouts across the week. It can be every day. It can be a few times a week. It doesn't have to be all at once. But then in particular, the American College of Sports Medicine endorses resistance training, or also known as strength training. These are those exercises that are meant to strain the muscles and the bone to make the body stronger in terms of the musculoskeletal system. And wherever possible, to do regular physical activity and to spread it out. So these are a lot of guidelines. It's a lot of consensus from our professional societies saying this is what we should do, this is what is good. Unfortunately, depending on the data source that you use, only 10 to 20% of cancer survivors in the United States are actually meeting this guideline. More individuals are more likely to meet the aerobic guideline, doing more of that aerobic intensity, running, jogging type of exercise than the muscle strengthening exercise. But 1 to 2 in 10 is insufficient. And what this means is that folks are not only not getting that physical activity, it's worsening their health outcomes. It's not for lack of trying. We know that there are myriad barriers to starting these programs. So the question is, how do we improve this? How do we get physical activity and exercise interventions into the hands of survivors? And in particular, what does this look like in rural areas? How do we do exercise interventions there? It's uniquely challenging in rural populations as compared to urban population, as we know that there are significant gaps in access and health outcomes. An easy one to point out is distance, that these individuals live farther away from gyms or YMCAs or personalized resources. However, there's also socioeconomic disparities across rural populations. And we know when it comes to cancer care that there are longer travel times and oftentimes worse care in these rural populations. We recently published using data from the SEER HINTS database that showed that individuals who lived in rural areas are actually doing less total physical activity than individuals who are living in urban areas. And we also found that individuals in rural areas had a higher burden of difficulties with activities of daily living. So coupling these two together, we know that these populations have more burden. We know that they have less access and they have less physical activity, which makes it ripe for interventions. Is some great ongoing work trying to address exercise and exercise interventions in community and hospital settings. There are several going on, but there's two in particular I'd like to point out. The first is the Nurse Amy intervention led by Dr. Katie Schmitz at UPMC. This is a tablet-based intervention that is meant to test in an efficacy setting if the tablet can be efficacious for improving symptom management for rural survivors, and if that is associated with better survival. The hypothesis is that technology can be one of the ways to reduce the gap in access by helping these individuals in rural areas get support for their symptom management and therefore ideally improve their overall survival. The other intervention that's underway and that has been tested is Laura Rogers' work from the Beat Cancer. Beat Cancer abbreviates Better Exercise Adherence After Treatment, and she has been extremely prolific in developing this intervention for breast cancer survivors. This Beat Cancer intervention was an aerobic-based physical activity program that targeted quality of life and functional improvement for breast cancer. She has been working on this for quite some time and has shown time and time again that the Beat Cancer intervention is not only efficacious, it's effective in the community settings for rural cancer. Recently, Dr. Cher Mama has picked up and adapted this intervention to focus on mindfulness, which is the latest iteration of Mind Your Beat, where she was able to tailor that Beat Cancer intervention to focus on other barriers and mind-body strategies for breast cancer survivors in rural areas. Some of our previous work, in addition to community and hospital settings, is we have tried exercise interventions in the home, which has great reach and ideal implementation for rural populations. With our studies, what we'll do is we send toolkits to individuals so that they can exercise in their home. This is a video of one of the resources provided to participants so that they can access the educational materials at any time that they are comfortable. We send them home with materials, which include resistance bands and dumbbells. We also give them a lot of education and knowledge, explaining what are the different muscle groups, what are the different body parts we want to be working. And in particular, we give them a tailored exercise intervention. How many sets, how many reps, what is particular for you. And while this approach is great for the individuals who enroll in the trials, this is challenging to sustain, and it's hard to implement on a broad scale, that tailored approach. It is better than the one-on-one supervised training. We've also recently looked at other urban-based exercise oncology programs that have been able to implement a specific exercise oncology program within their healthcare system. So one of the examples here is the Huntsman Power program in Utah. In their cancer center, they have this fantastic exercise resource by which individuals can get their exercise in their cancer center as part of their cancer care. As a part of this analysis, we looked at different healthcare systems that have been able to implement these programs and identify some of the implementation constructs that allowed them to be successful. So for example, having financial support from the healthcare system was one of the facilitators that allowed these programs to be successful. Financial support is not going to be the same at every cancer center, and in particular in lower and rural environments where the resources may be tighter, it is far more challenging to implement programs like this. So we've been able to identify what is working well in urban areas, and then recently Dr. Prajakta Asdul wrote this excellent piece about what the specific elements and active ingredients are necessary for developing these exercise oncology programs. So, for healthcare systems or for hospitals that really want to take this evidence-based practice of exercise oncology, also known as exercise for cancer survivors, they must have systematic planning, institutional support, integration into the clinical workflow. So, for most individuals, that's Epic or their healthcare system, and sustainable funding. As we think about making these exercise oncology resources more accessible, it requires intentional planning from the start and really integrating multiple pieces from the healthcare setting that are successful. However, this report was related to urban settings. And when we think about implementation in rural settings, it will probably require different solutions. We have seen this time and time again that the resources are different and they're often lower in rural areas compared to urban academic settings. Infrastructure is different across institutions, and that's true across the board. The, the way that we can embed exercise oncology into clinical care will vary. That is related to priorities and different levels of readiness at the organization. And when we think about rural populations in particular, there is a lack of realistic options to refer them to. Locally, in urban areas, there are oftentimes personal trainers, community gyms, or established programs like the YMCA Live Strong program by which survivors can go to get tailored exercise oncology programming. As part of the Moving Through Cancer Task Force, we were able to map those specific exercise oncology programs. So these are existing programs that are meant to serve individuals with cancer across the United States. And you'll see from this heat map, the dark red color indicates a exercise oncology desert. So access and proximity across the United States for exercise oncology programming is not the same. As you eyeball this map, you'll notice that these deserts are often associated with rural areas. But even with this orange color on the heat map, we shouldn't expect survivors to drive 50 miles to an exercise oncology specific resource. So it's important to think about how we can implement this evidence-based program in local settings, such as at cancer centers where we know people live and are going for their treatment anyway. At this point, we're going to transition into thinking about implementation of that evidence-based program. And as a non-implementation scientist, but as someone doing implementation science work, I really like this article from Curran, who explains when we're thinking about the evidence-based program, what are we thinking about? We're talking about the thing. So for us, we're thinking about exercise oncology as the thing. How do we get the exercise oncology program into the institution? Does it work? Why did it work? What are some of the barriers that prevented it from working? And we'll come back to this. And so for the final part of my talk today, I'd like to talk to you about the ICANN network and what this work looks like in practice across the state of Iowa. My colleague, Dr. Seaman, led the first talk in this series about the Iowa Cancer Affiliate Network, abbreviated ICANN. And this is a network of rural hospitals established by Dr. Mary Charlton as part of her R01. And these are small rural hospitals that are located in rural counties. And these are RUC codes, RUCC, between 4 and 9. In each of these hospitals, in order to be enrolled in the original trial, we're pursuing accreditation from the American College of Surgeons Commission on Cancer. Now, the Commission on Cancer accreditation is associated with the highest level of care, and there are multiple standards by which each institution has to meet the standard in order to receive accreditation from the Commission. Leveraging this established network, I was able to lead a qualitative analysis to do semi-structured interviews with each hospital in the network at the time. And to reorient to where we are, this is the beautiful state of Iowa, and those circled hospitals are the participating hospitals in this interview project. So I currently live in Iowa City. That is where we have our one NCI designated comprehensive cancer center, but we have pretty good representation from the different corners of the state, serving different communities all across the area. Now, I've talked about the Commission on Cancer standards. One of the reasons why the discussion and the query about exercise and physical activity is important to the COC accreditation because physical activity falls underneath standard 4.8 for a survivorship program. So in order for hospitals to receive COC accreditation, they have to have an established survivorship program. Now I've screenshotted the standard from the COC here. Survivorship program services can include uh, physical activity programs or classes. So by this way, it is one of the ways we can explore if physical activity were to be implemented, is that helpful for survivorship programming and for meeting that COC accreditation standard? So in order to do these interviews, we developed an interview guide, reviewing the literature, taking into consideration some of those barriers and recommendations from Dr. Asdul of what are some of the pieces that need to happen for an exercise oncology program to be successful. So for example, institutional readiness, we asked about electronic health record integration, questions like that. And with these interviews, they were one-on-one, and we were able to interview with representatives from each center. We gave latitude. So this included directors of the cancer center. Some of these were people directly related with survivorship care. Now, this might be a nurse navigator or a survivorship coordinator. We were able to talk to a few oncologists and some robust physical therapy programs to ask them about physical activity programming and exercise oncology as well. From across the 5 hospitals, we did at least one interview with an individual. Most did two. So we had a total of 11 interviews. They were 45 to 60 minutes in length, and we recorded them and then transcribed them. As part of the qualitative analysis, we took an established implementation framework, the CFIR framework, and we were able to identify some of the main barriers and themes identified by the programs, mapping them onto the framework, which allows us to identify what are some of the next steps for moving forward. And I'm coming back to the Curran article about when we're talking about this interview, what is the thing? We're talking about the evidence-based practice of exercise oncology. So what does it look like to implement an exercise-based oncology program at your facility? What do you know about exercise oncology programming, etc.? And I want to I want to talk through some of our main themes. These interviews were incredible. We had great participation, and people were very forthcoming and kind with their time. We had a lot of themes identified from these rich interviews. So I just want to highlight a few of the main ones that are going to inform the next steps of how we're able to implement these programs in rural environments. So the first theme we saw when we were asking about awareness of benefits of exercise and established exercise oncology programs, we identified that there were barriers, both barriers at the level of the patient and at the healthcare providers. Some facilities reported an underutilization of available resources, such as physical therapy services. Some facilities said that they had really robust physical therapy gyms, but some patients were not willing or able to come back to use them, oftentimes due to socioeconomic issues and or transportation. Across the networks, it was pretty clear that the institutions, the leadership, and the providers were aware that there are great health benefits of exercise. However, it sounded like it was mixed on the level of the patient. It's really challenging to get a patient to do a behavior if they don't know about the necessary health benefits. Some of the examples that were brought up were some of the patients thought that they should be resting during chemotherapy or that they weren't allowed to exercise because they were waiting for surgery. As we talked to these sites, available resources varied. Some individuals were aware of local YMCAs. Some people didn't know if there were other resources online. And one of our conclusions here was that as we think about moving this forward in Iowa in particular, an important implementation strategy could be educating patients about available services like exercise programs and physical therapy, some of those that are already available in their community, as one example. Another theme we found is how we could leverage existing policies or incentives at the level of oncology care. So In other countries, for example, like in Australia, they have policies that enforce the need for exercise oncology programming or an individual getting so many sessions of exercise oncology. Here in the States, we don't have any policy like that, but there are existing incentives, such as the Commission on Cancer accreditation, which could be leveraged here. When we talk to the participants across the sites, there's no formal policy from the state or from the federal government saying that there has to be an exercise referral or there has to be every patient has to be seen by physical therapy, for example. So, with a lack of existing policies and incentives, that changes the level of intervention. We're probably working on an organizational level if we can't leverage the state or federal policies. A third theme we identified was what is the supportive culture for oncology care and supportive services within organization. Across all sites, there was minimal to low awareness of existing exercise oncology services within their organizations. And this is not at all surprising. There are very few exercise oncology services nationwide that are embedded within the healthcare system. That analysis that we led, I mentioned before, we were able to identify 5 across the United States. And since then, there have been a few more. So this is nothing against the individual organizations, but it is important to note that there's low level of awareness because it doesn't exist. Furthermore, the organization's staffing and location impacts the ability to implement something like an exercise oncology program. So if you were going to build an exercise oncology program at your cancer center, you would need space, you would need staff, you would need a way to track the behaviors and the performance, you would need equipment. In these cancer centers, it's not obvious to just hire someone into that role, especially when exercise oncology isn't billable immediately. So the culture certainly impacts the ability to implement an evidence-based practice like exercise oncology. Another area we explored was organizational readiness. That's fine. These places don't have exercise oncology programs. Could you be ready? What does that look like? And the state of the infrastructure was mixed. Some places that had strong physical therapy programs, for example, could certainly tailor that pathway and make it more about exercise oncology, given that they already have certain expertise related to their institution. Some individuals had really strong external partnerships with other existing programs that could facilitate ongoing collaboration. But then some places just simply have limited availability of collaborators, tracking, or documentation. So across the network, it's not one answer. There is a mixed milieu about organizational readiness across the network. And overall, in their communities, when looking at each of the cancer centers locally, there was a lack of specialized exercise cancer training and a reliance on general fitness resources. This isn't necessarily a bad finding. It is important to note general fitness guidelines for adults are not that dissimilar than that for cancer. For individuals who've had a cancer diagnosis and who are on the survivorship continuum, they may have cancer-specific concerns like ostomies or peripheral neuropathy or that fatigue we've talked about before. So the general fitness resources are not bad, they would just be incomplete for some of those cancer-specific concerns, which is their identification of the lack of specialized cancer exercise education, which is a potential future area of exploration. And finally, the last theme I'd like to talk about is the importance of leadership and interdisciplinary collaboration for oncology care and how exercise as supportive care can fit underneath that. These hospitals in the ICANN network have a supportive leadership structure. They wouldn't be in a study, they wouldn't be trying to pursue COC accreditation if they didn't have supportive leadership environments. So that is the caveat for this interview when we're thinking about external generalizability. However, the level of strategic efforts and interdisciplinary collaboration will vary given what each institution has in terms of their expertise. Some leaders are very supportive and they really want to focus on improving survivorship care. Some individuals really want to focus on surgical outcomes. Some individuals really want to focus on supporting their staff and retention. And a way that we can use those different strategies and incorporate exercise oncology, leveraging the leadership vision, is one of the ways that we can move this implementation or move this project forward. This data is really rich, and the interviews were a privilege to conduct. There isn't a single solution, but we do know that the tailored solutions have to take into consideration the context, the environment, and the barriers for each of these individual facilities in order to make this possible in rural areas. So we have finished these interviews and we are working through all of this rich data. And our future directions include scholarship in particular. We're taking some of these themes and we want to then map them onto the implementation strategies. Everything I told you about those thematic findings are some of the things we're finding. The themes, the barriers, the facilitators. Now what we want to do is take those considerations and put them into action through implementation strategies. Given that we're at an academic medical center and that we are a comprehensive cancer center, I think education at the facility level is a priority of mine. And I think it is one that would be one of the easiest to implement, or the quickest rather. And as we move forward, in addition to identifying the specific implementation strategies, we know that we, as the Comprehensive Cancer Center for the state, should be supporting these hospitals in a network fashion. What does that look like specifically? How can we, as the Comprehensive Cancer Center, provide support to each hospital remains to be seen. But I think that is our priority and that is our role. Coming back to Dr. Asdul's analysis from before, it's easy to say that these things should work a certain way. This is far more complicated than it sounds. We know that there are guidelines from national organizations recommending these programs. Is there provider readiness? Do we need to change infrastructure? What are the implementation toolkits? That's based on the implementation strategies. The practice change that we have to do at each of these organizations will take time. And that's if folks want to change their practice. The goal here is to help individuals with cancer survivors across the state, improve their physical activity and their health outcomes. So there will not be one solution, but we're looking forward to figuring out what works and why. So in summary today, we talked about the physical activity recommendations. Those include both aerobic and resistance exercise. Some of those health outcomes that we've talked about include cancer-related fatigue, anxiety, depression, bone health, sleep, and physical function. There are disparities in access to exercise oncology resources. In particular, they are worse in rural areas. And then finally, we've talked about a few existing evidence-based exercise programs. I briefly talked about my intervention to help improve outcomes for cancer survivors. So this is a great work in progress. I'd like to thank my team, everybody from the ICANN network, all of the interviewees, and I'd be happy to take any questions, and I look forward to the discussion.
Thank you, Jess. That was great. What questions do people in the audience have?
Nora, should I stop sharing my slides?
If you'd like.
I'll keep this up in case anybody wants to grab my email.
So if you have any questions, now is a great time to ask them. Well, I have a question, which is, can you tell me more about what is there emerging research in this field that's on the horizon for you or that we should look out for?
Yeah, one of the most exciting studies that I didn't put into this presentation that is really changing the field is the challenge trial. This is a trial from Carrie Kernier up in Canada, and they were able to show that a semi-structured exercise program improved progression-free survival for individuals with colorectal cancer over a 3-year period. And they were able to show that exercise was as good as some of the chemotherapeutic agents on the market for improving survival. It was something like an 8% difference for individuals who exercise versus those who did not, um, which is compelling, right? It's really exciting. We've known this for prostate and breast cancer for a while, that exercise is associated with better survival outcomes. But this trial was happening for over a decade. And to see that precise estimate of how much exercise is really extending the lifespan is really riveting. So there's more work in that area for helping to identify exercise as medicine with survival. And then I would say there's some great molecular work for individuals trying to understand how exercise can help reduce tumor burden, shrink tumor size, or reduce the vascular composition of tumors. That's above my pay grade. I don't really do the molecules, but I will say that's really exciting to see how exercise can sort of tailor and adapt cancer treatment to make it more effective.
That is very exciting. Yeah, thank you. Looks like we've got a few questions coming in. One person asks, if you were to ballpark the number, how much is the state of Iowa getting from the current federal administration for cancer research?
That is a great question. I'm not, I don't even have a ballpark figure. Um, I'm aware of some of the federal funding that we have received at the University of Iowa. And I'm sure there's also support being given to the state, to Iowa State University and probably Northern Iowa as well. Um, One of the things that I'm not totally sure about is the proportionality of the support to the burden. Maybe you've heard Iowa is infamous now. We have the second highest rate of cancer in the United States for age-adjusted rates. So we're going up when everyone else is going down. I would argue that that's a pretty big issue and warrants investigation, and that requires a lot of resources. But that's easy for me to say from my perspective.
Yeah, thanks for that answer. Let's see what other questions we have. Someone asks, do you have a reference list from this presentation so we can read these articles?
Yeah, nor can I get that to you and then can it be disseminated?
Sure. Yeah, thank you. Librarians are always asking for references. Um, let's see. Okay, here's a good question. Does the physical activity intervention encompass nutrition slash healthy eating factors, or are there plans to collaborate in the future?
This is a great question. My joke is that the only thing that's harder than measuring physical activity is diet. So for example, did you eat carrots last week? How many carrots? Were they organic? Were they peeled? Did you boil them? It's really, really challenging to do dietary research, which is why I like to stay in my lane. We know that diet and lifestyle interventions combined can have multiplicative improvements. So exercise is good, dietary improvement is good. Shouldn't they be more good together? Um, Currently, we have some plans to develop some interventions there. For me in particular, one of the things I'm really interested in is the strength piece, that muscle strengthening resistance training component. There, we have a lot of work to do with protein and composition of diet. But of course, we know the role of obesity in cancer carcinogenesis. So there's a lot of great work happening nationwide, looking at some of these combined interventions beyond my work as well.
Yeah, it sounds very challenging to measure nutrition. Uh, Mary has posted a link to the challenge trial article in the chat box if anyone wants to see that. Um, and let's see, we have another question. Do you have any theories on why cancer rates are higher in Iowa than in other states?
No, I have hypotheses. Because, I'm from Wisconsin. So a lot of people are quick to point to drinking, but I think the state of Wisconsin drinks more. People are quick to point to obesity, but there are states that have higher obesity rates. For physical activity, we're not the best. We're right around average. Because we know that there's not one cause of cancer, it's probably not one thing. My hypothesis is that it's a marginal effect of multiple factors, but the exact combination is for the epidemiologist to figure out. There is a lot of mobilization and concern about the agricultural part. And I think that the environmental exposures are certainly worth investigating. So personally, I don't think it's one thing because we know that cancer is not caused by one thing. The multitude of cancer control strategies, I think, can help to reduce that burden. Um, so I'm trying to stay in my lane and help with exercise where I can, but there is certainly more work to be done.
Thank you for that thoughtful answer. It's always hard to.
It's a good question. And I mean, I live here, I'm raising my children here. Like, I'd like to know too, it's important.
We have another question from someone who says, I am with the American Cancer Society, where we generally talk about and completely support the notion of exercise oncology. Are there ways ACS can help support/implement your efforts? If so, how? Thank you.
Uh, That's a great question. Thank you for asking it. One of the things that we've been working with is our local Hope Lodge for ways that we can potentially connect some of these remotely delivered interventions or screens so that when folks are staying at Hope Lodges associated with the American Cancer Society, that they could be able to plug in here. Um, I also think that's a good question to take back to our affiliates, to each of the rural ICANN hospitals to see what do they think. Because it's easy for me to say, I think we need this, but I'd love to connect with you as a follow-up to see um, what that might look like.
Um, and her email is right there. So you can
Thank you.
connect afterwards. Um, this question says, wonderful and interesting information. Thank you. Are physicians around the US trained to provide this information on the benefits of exercise to cancer survivors in their care?
This is such a good question. Um, my day job, I also teach. I'm a professor, and I work in a department that has a lot. It's basically a kinesiology program, and a lot of our students are pre-med. Um, but the exercise-based training provided to physicians in training is very, very minimal. Um, this level of detail I do not think is covered in medical school. This is one of the big questions we have. Should the providers or oncologists or physicians, should they be the one prescribing exercise? In theory, but that's my discipline. That's what I went to school for that specific expertise. In the way that you wouldn't want me dosing chemotherapy, we probably wouldn't want physicians giving a personalized exercise program. So it's a way to balance getting the providers and the physicians bought in to recommend, a warm handoff or a referral or anything there to recommend to resources. But I personally don't think it's the role of the physician or the oncologist to write up an exercise plan. Some will, and that would be great. I worked with a oncologist at MD Anderson who used to tell his patients to exercise or die. And he would say that, and then he would talk to our team and say, go talk to these exercise nerds. They're going to get you ready for surgery. I don't necessarily endorse that level, but knowing that there is a healthcare shortage and knowing that time is money, and again, this isn't necessarily billable at this point. What I think would be great and sustainable is that sort of integration across multiple disciplines to hand off from one team to the next, which is great in theory, right?
Thanks, Jess. We do have one more question. No, we have multiple questions. They just keep coming. Great questions, everyone. This one says, as a clinical exercise physiologist that has specialized in cardiopulmonary rehab, I am looking for additional training/courses to learn more around exercise oncology. In addition to the ACSM ACS Cancer Exercise Specialist course, do you have other recommendations?
Yeah, so that would be my first recommendation. The CET exam from ACSM ACS is fantastic. And with that class, Anna Campbell was modifying a lot of the material from CAN Rehab. So her courses, if you really wanted to dive into it, her CAN Rehab program, I think is phenomenal. The University of Northern Colorado has an internship program that I've heard about. I personally have not enrolled in that gives trainees a more specific, dedicated in-person training opportunity to work in person. One of the efforts we're trying to launch here at the University of Iowa is launching an exercise oncology clinic where we're going to take undergrads who might not have that CEP certification, expose them to exercise oncology, and put them in the clinic in an internship setting, working directly with patients. So I believe that not only the didactic work, but that practical application would be really helpful for exercise oncology as well.
Thanks. The next question is, do you know if Iowa has lower prevalence of aerobic exercise than other states, i.e., are Iowans more sedentary than people in other states?
This is a great question. This is an issue with the way we measure things. So when I talk about, so there's physical activity as the big umbrella, and that is any voluntary muscle movement that increases energy expenditure above baseline. So as I'm standing here gesticulating, like this is technically physical activity, but I'm not doing it for a fitness benefit. So this wouldn't be considered aerobic exercise. When I go walk my dog intentionally to get my heart rate up, that's aerobic exercise. When we look at physical activity epidemiology and some of our surveillance tools to look at population health, we're often just getting a rough approximation of physical activity. So, Nora, in the past 7 days, how many days did you do housework for longer than 10 minutes? How long was that duration? So, we're able to get this really rough approximation of total physical activity. And of course, exercise is a part of physical activity, but the estimate we're getting is pretty big. That said, Iowa is slightly less active based on our physical activity assessments than other states, but we're within, I think the last time I checked, I think we were 30th nationwide. So again, that we're less active, boo, but I mean, it's not where it jumps out as an immediate area of intervention. And I would point out the sedentary part is big too, because being physically active is one part, but sitting is a separate behavior. You can be physically active and like get your exercise in, but if you're sitting for 10 hours a day, that's also a risky health behavior. It gets really messy, right? And I'm not here to shame people, and a lot of us are chained to our computers. So sedentary activity and physical activity are related but separate constructs.
So hard to isolate one factor uh, when we look at cancer. I see that our chat box is filling up with comments about the environmental factors, which are, of course, also of a concern and hard to isolate from all these other factors.
And I would say, that type of, there's a reference before to um, federal support. A question or a concern like that, I think would be appropriate to speak to someone's representative about. If someone felt so inclined. I'm just an assistant professor. I know things and talk about the things. But if a person was so interested, they could talk to their state and local representatives about action.
So many great resources and information, says someone in the chat, and I agree. Any last questions uh, before we wrap things up? Well, thank you, Dr. Gorzelitz, for being here and for presenting. And thank you to everyone for attending. I'm uh, going to share my slides, and you can see the link to the evaluation, which we will also put in the chat box right now. So you can click on that evaluation link or enter it into your URL, and from there you can claim your CE credit.
Nora, thank you for this opportunity to talk about our work. Thank you again to all of our Iowa affiliates, and I will happily get you that reference list for dissemination.
I appreciate everyone's time. And just a quick save the date that we have our last webinar in this series, which Dr. Gorzelitz helped arrange as well. So thank you. Which will be on March 3rd, a provider's perspective on building high quality cancer survivorship care in rural areas. And that will be on March 3rd. We'll also have a number of other webinars coming up that offer CHES credit or might be interesting to health professionals and information professionals. So if you're interested in registering for those or attending them, check out nnlm.gov/training. And with that, I will wish everyone a good afternoon. And feel free to email me or Dr. Gorslitz with questions. Thank you.